Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. DrAndyRoark. Guys, I am here with the one and only Dr. Anna McManamey, a.k.a. Dr. Mac. She is a assistant clinical professor at Purdue. She's amazing. I love talking to her. Guys, I got her in for this episode of just running through my congestive heart failure medications. So she's going to run through the cardiac medications on the shelf in relation to congestive heart failure. And just breaks down real quick. This is what you use this for. This is what I reach for this for. This is what you pay attention for with this. Man, it is like 15 minutes of just jam-packed education and pearls. So good, so useful. It's great for veterinarians. It's great for your technicians as well to listen to. But whether it's a refresher for you or it's just new information as you're learning your cardiac medicines, this is a great episode. I'm so thrilled. Guys, let's get into it.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. DrAndyRoark.
Welcome to the podcast, Dr. Anna McManamey. How are you?
I'm good, Andy. How are you?
I'm so good, man. It's good to have you back, Dr. Mac. I love having you on the podcast. I'm super excited today because I think we got one of these really, really, really useful episodes that people love. I wanted to run through the cardiac drugs in my clinic with you and just 100% get a refresher crash course of what's on the average vet clinic shelf, when do you use it, when do you not use it, just like that. And I think it's great. It's great review for me. I did this with Tasha McNerney on anesthesia drugs in the anesthesia crash cart recently, and I loved it. It made me feel so like resharpened, and I just want to do that with you. Is that okay?
I'm so excited. It's great.
All right, let's do it. Where do you start when you look at your average vet clinic cardiac drugs?
Yeah, so I think for me, there's kind of two categories that I would want to stock. And so being in the ivory tower, I'm very spoiled, like everything is at my fingertips. But when it comes down to what I need to have there and then, I would say for the category of congestive heart failure management, I would include drugs, first and foremost, furosemide. So that's going to be the go-to diuretic. It still is. Furosemide is also Lasix. It's given that name because it lasts 6 hours in the bloodstream. So that's why it's given the name Lasix.
I had no idea.
Isn't that cool? Yeah.
I had no idea that was
I
true.
didn't learn that till I was a resident, so it's not common knowledge. But that's why it's called that. So furosemide, any of the semide drugs, those are going to be your loop diuretics. So they're still the most effective diuretic that we have for treating congestive heart failure. The nice thing with furosemide is that it is oral as well as injectable. So having a bottle of injectable on your shelf, I think, is super important. You can give that subcutaneously, you can give that intramuscularly, or you can give it IV. If I've got an animal that is clinical enough where they need oxygen support, I would recommend avoiding the subcutaneous dose. I would only do IV or IM just because at that state, they're not really perfusing their sub-Q very well. So, but Gotcha. It's nice because you can give it any way you want and it'll work. It works quick. It's just still the best one I got. The next drug on my list would be Pimobendan, which I do vitamin P. I'm very obsessed with this drug. But Pimobendan, especially in dogs. So in the canine world, Pimobendan or Vetmedin is going to be the go-to next drug for me. This is one that has proven time and time and again to be beneficial for these dogs' quality and quantity of life in the state of congestive heart failure. And it's even been shown to help these dogs before CHF even happens. So a few reasons to keep it on the shelf. But this drug has two main mechanisms. It is classified as an inodilator. So it's a positive inotrope, meaning it improves the contractility of the heart. It does this by basically causing more of a chance for the actin and myosin to meet, cross-link, and form a cross bridge. So it's a calcium sensitizer, which is kind of unique because it doesn't change the amount of calcium inside of the heart cell, which like digoxin is an old tried and true drug. That does do that. And the downside of increasing the amount of calcium in the cell is it's pro-arrhythmic. So the benefit with Pimobendan is that less likely to develop arrhythmias secondary to the drug.
Gotcha.
The other benefit is that it is an inodilator, so it's a vasodilator. So it actually does decrease the afterload on the left ventricle as well as sometimes the right ventricle based on where it's going to cause vasodilation. Typically, it's the veins, so we don't see systemic hypotension develop with this drug, which is another benefit compared to something like an ACE inhibitor, for example. So 2 big reasons why I keep Pimobendan high on my shelf, or I guess I should say low on my shelf, but high on my list, because it's something that's good for really any type of acquired canine heart disease, whether it's degenerative valve disease or dilated cardiomyopathy. I will use Pimobendan in some cases of cat heart failure as well. So if I've got a cat who has congestive heart failure, doesn't have a loud murmur, then I feel a little bit more comfortable using that drug. It is definitely considered off-label for that purpose, so you do have to have that conversation with your client. But if I have a cat, especially these older kitties that already have a degree of kidney disease, it's nice to conserve the amount of Lasix that I need for that patient. So that's number 2. And then kind of staying on the cat theme, I would say having Clopidogrel or aspirin, something for blood thinning. Basically, cats that have congestive heart failure, they are going to have large atria. And one of the side effects and risk factors for cats with big atria is aortic thromboembolism. So don't forget to add that treatment arm in there. We have evidence in the veterinary community that Clopidogrel outperforms aspirin. So that's my choice, is Clopidogrel. There's injectable medications you can use as well, but Clopidogrel is kind of the easiest, I think, for most clients. And it's once a day, which is nice. And it's affordable. And then the other thing for cats, I would say, I don't think it's as much of an emergency drug, but would be things like Atenolol, which is a beta blocker. And we used to use this a lot more commonly in cats until we found out that doing large retrospective studies and even some smaller prospective studies, Atenolol in the asymptomatic stage of heart disease in cats doesn't seem to correlate to longer survival. This kind of all came from human medicine, but I do think there are still going to be some cats that will benefit from Atenolol therapy. Those are usually cats that have loud heart murmurs or cats that have tachyarrhythmias, so fast heart rates. Atenolol is also an antiarrhythmic. It can be used for supraventricular arrhythmias as well as ventricular arrhythmias in the cat, and is usually pretty well tolerated. And I also will use Atenolol in cases where I've got a cat that has like a thyroid storm, so thyrotoxic heart disease. Atenolol can be useful for those cats too.
Hey guys, I just want to jump in here with a quick update. Have you seen the Dr. Andy Roark team training courses yet? Guys, over at DrAndyRoark.com, I have got resources for people who want to work with their team. I have my Angry Client course and I have my Exam Room Toolbox course. These are great little modules that are made to be broken up and popped into staff meetings so that you can cover a quick topic about either dealing with angry clients, complaining clients, or to talk about different tools in working with clients in the exam room. Guys, this is fantastic. I've got discussion questions to ask your team so they can talk about what they do, and just is a great way for everybody to see the same thing together, to talk about what works in the practice and what and what they think is important, and just to get on the same page. Anyway, I hope you guys will check it out. It's over at DrAndyRoark.com. I'll put a link in the show notes. Let's get back into this episode. Are you using Atenolol in dogs at all?
The only real indication for Atenolol in dogs is obstructive heart disease. So in dogs, the most common forms of obstructive heart disease are congenital. It's subaortic stenosis and pulmonary stenosis. So in those animals, the Atenolol is purely myocardially protective. So usually I'm using that in the asymptomatic stages and then adding in a diuretic once they develop congestive heart failure. But it's rarely going to be a drug that I am pulling off in case of an emergency, if that makes sense. So usually the cardiologist rule is don't give a beta blocker to a wet patient. So a patient that has active pulmonary edema or pleural effusion, you probably run a greater risk of just worsening their heart contractility and lowering their heart rate when they need those things in that emergency setting. But still one I think is worth having around.
Okay, perfect.
And then the final one I have really is just in cases, but is Amlodapine. So this is a blood pressure medication. It is a calcium channel blocker. It really acts preferentially on the cardiovascular system and just the vascular aspect. So we don't really see changes to the heart itself with Amlodapine. But out in the blood vessels, it causes vasodilation. So this is another drug I can use in kind of two ways. Both of them have the same goal. The goal is to decrease the afterload on the left ventricle. So if you are a cat or a dog and you have systemic hypertension, well, amlodapine will vasodilate your blood vessels, drop your systemic blood pressure, and that decreases the work on that left ventricle. Conversely, if I have a dog that has really bad mitral valve disease, really a lot of mitral regurgitation, even if they're not textbook systemically hypertensive, so I'm talking about a blood pressure that's less than 160 millimeters of mercury systolic, but greater than 120 millimeters of mercury systolic, so kind of a small window, but a lot of dogs fall in there, I might use a little dose of amlodapine to drop that afterload on the left ventricle, because whatever pressure is in that aorta is the pressure that left ventricle has to generate to get blood to go forward. So it's kind of this fun hemodynamic game I can play with severe mitral valve disease dogs that can kind of preserve the need for a lot of diuretics. And so I call it a fun hemodynamic game. I think other people are too.
No, I just love that that's how you see it. I'm like, oh, this is a person who loves their job. I love it.
So it's just kind of finding those balances. What can I manipulate to improve cardiac output? So I would say, again, those big kind of 5 drugs for me would be furosemide, so my loop diuretic, Pimobendan, my inodilator, Clopidogrel for kitty cats as a blood thinner to prevent ATE, and then amlodapine and Atenolol just kind of on standby for those instances where they might come in handy. I think other drugs that I have to talk about, but I don't think have to be on your shelf for like a quick grab, are your ACE inhibitors. So the Analypryl, Azapril, those Pril drugs are very important to the long-term management of heart disease. So these have definitely proven their use in congestive heart failure patients long-term. Same thing goes with Spironolactone, which is an aldosterone antagonist. So the ACE inhibitor and the Spironolactone together do a really nice job blocking the RAS system. So trying to prevent the formation of angiotensin II and aldosterone, because both of those hormones are automatically activated in congestive heart failure. And ironically, they get upregulated when the patient's on a diuretic. So we have 2 reasons the RAS system activates with congestive heart failure: the state of CHF and the fact that we put them on a diuretic. So we kind of need to suppress that system in order to have the best long-term prognosis. So these drugs prevent the angiotensin II and the aldosterone activity, which in the body, the reason cardiologists don't like those hormones is because those both cause vasoconstriction that increases afterload on the heart. They cause water retention and sodium retention, which increases the preload to the heart. They have fibrotic mechanisms, so they actually cause fibrosis within the heart, the blood vessels, and even the kidney, the glomerulus. So chronic activation of these is maladaptive. So those are my CHF drugs. Yeah.
Gotcha. I love it. Can you give me some wisdom, some of your little pearls on dosage and frequency with Lasix? It feels like voodoo to me, where you kind of go, I don't know, maybe a little bit more, and like let's just try 6 hours instead of 8. I know that some of it's more art than science, but help me. How do you get your head around that? And then when you're talking about adding your ACE inhibitor and your spironolactone, stuff like that, I go, how do I manage these things together? Because I feel like it feels like a blunt instrument in my hand sometimes, Lasix specifically. Help me feel a little bit more, I don't know, a little more nuanced in that usage, please.
Sure. It's a great question. I always kind of, we always tell students, go look up the dose and tell us what you want. But if you look up the dose of furosemide, it's like huge. 1 to 4 mg per kg, 1 to 6 times a day. Like there's
it's huge.
So the nice thing with a diuretic is that it is a high ceiling diuretic. So you keep giving more until you get the effect that you want. And if you overdo it, you just scale back. And so really it's very much an art and kind of a gut feeling. And so what I would say is a very standard starting place for Lasix therapy, I would say in a dog, is usually 2 milligrams per kilogram every 12 hours.
Okay.
In a cat, we're usually a little bit more conservative. Again, most of them are a little bit older cats. They also might have underlying kidney disease, and their plasma volume is just different. So we usually do 1 mg per kg every 12 hours in cats. It's usually a pretty standard starting dose. I would say that if I'm going to start a diuretic, that patient's either about to be in CHF, like they have enough clinical signs and enough concern, or they're already definitely in it. So when I start that medication, I'm not looking to take it away later. So I've seen those protocols where you start them high and you taper them off of the drug. I don't think that's going to work for most of these patients. So I pick a dose, I start there, and then really it's about teaching the client to count breathing rates at home and use clinical signs and your blood work, as well as any imaging you can acquire to help you fine tune that dose. So what I do with my patients when I discharge them from the hospital, I say you have the diagnosis, it's CHF, congestive heart failure. We're going to start a diuretic. Again, 2 mg per kg BID for a dog, 1 mg per kg BID for a cat. I let them know this does increase urination, so they will be very thirsty and they have to always provide water. I also let them know that the medication takes effect about 2 hours after they get it orally. So they will really have to go potty about 2.5-ish hours after it's given. So that can save some of the 2 a.m. trips outside if you don't give it at midnight. So those are the little pearls for the clients. And then really it's, are their breathing rates less than 40 when they're sleeping? Is the coughing improved? Are they eating? If they're doing those things, I'm happy with my dose. If the breathing rates are over 40 when they're sleeping, breaths a minute, if they're still coughing a lot, I would increase my dose by about 25% over the course of the day. And if that's still not helping, I'd say I probably need to get you back in and see if we made an improvement radiographically of what's going on, or am I targeting the wrong thing, what have you. Typically, my recheck plans are radiographs, physical history, and then looking at renal panels. So the BUN, the creatinine, and the electrolytes, those things help tell you if you're overdoing your drug. So that helps me know if I need to scale back. So I think using those two things together can help you make a more objective kind of decision about what to do. But in general, I start with that dose, 2 mg per kg BID for dog, 1 mg per kg for cat PID, and then I go from there. And if I'm not controlling clinical signs, I escalate my therapy by 25%. And that's what I do every time. There are some animals where I think if they're older, more crunchy kidneys, I usually like to spread out my dosing a little bit more frequently. So instead of doing 2 doses in a day, see if they can do the same daily dose, but 3 times a day.
Gotcha.
So maybe give the kidneys a little bit more of a break and the body more time to recover that volume loss. And then really from there, we tend to start considering doses over 8 mg per kg per day. That's when we're in the, wow, these are really high doses of diuretic.
Gotcha.
We either need to switch diuretics to a more potent one, or we need to escalate other therapies instead.
Gotcha. That totally makes sense. Man, this is fantastic. I really appreciate this. It was wonderful, wonderful, wonderful. It's a wonderful refresher. I really appreciate your time. Dr. Mack, you are an assistant clinical professor at Purdue. Where can people find you online? Where can they read more? Are there any resources that you're a huge fan of in the field of cardiology that you wish people knew about?
Yeah, you can Google me, Anna McManamey. I would put Purdue with it because the other Anna McManamey in the world is a beautiful blonde bombshell bodybuilder from Australia. He's not me. I have a lot to live up to with that, but yes, but Purdue, Anna McManamey, I'm on their website there. There may be some lingering stuff from me from NC State as well, but that's probably the easiest way. I think in terms of resources, I am a big fan of the cardiac education group. And I think I've mentioned that before on a podcast, but it is just cardiaceducationgroup.org. It is sponsored by BI, but it's really well put together. Many of my mentors help run that site. It's got great drug formularies for dogs and cats. It has like the doses, what tablet sizes they come in, which is also very helpful, I think, side effects. They've got practice cases. I just think it's a really good starting point. That and the VIN, I think, are probably my favorite.
Yeah. Outstanding. I'll put links in the show notes for that. Thank you so much for being here.
You're welcome. Thanks for having me.
And that is our episode. Guys, I hope you enjoyed it. I hope you got something out of it. Special thanks to Dr. Mac for being here. Guys, if you enjoy the podcast, leave me an honest review wherever you get your podcasts. It really does help people find the show. If you're like, this is great, share it with your friends. Spread the learning love. Anyway, gang, take care of yourselves. Be well. I'll talk to you later on. Bye.